UWMC Northwest Campus. From 2018 to 2021, she has spoken extensively, locally and nationally on her passion for supporting the emotional health of both patients and healthcare workers, and on creating a healthy work environment in healthcare. Sherry, thank you so much for your time and partnership to meet with our community of 93 people. That's amazing. Thank you so much. The floor is yours.
Thank you so much, Lauren, and thank you to Anna for all the arranging behind the scenes today. I'm really excited to be here talking about a topic that I'm very passionate about. And as Lauren said, in my role as the behavioral health clinical nurse specialist for 3 years on the Northwest campus, I really had the opportunity to learn quite a bit about the impact of behavioral health on our communities. And it was really very timely with the impact of the COVID-19 pandemic on all of us and on many of our mental health. So I'm going to talk with you today about trauma-informed care, and I'm going to go ahead and share my slides, and then you guys let me know if you have any issues with this. One thing I would ask is that if you don't mind keeping your camera on, I love it. If you do, you don't have to if you don't want to, or if you're trying to multitask or eat. But I just love to see faces. And I love if up in the upper corner of your screen, you put it on gallery view rather than speaker view. So you're not just looking at me, but you're looking at other people, I hope. I'm pinned though, maybe. I don't know if, can you guys see it like gallery view? Do we look like the Brady Bunch? Okay, perfect. Yeah, so I would much prefer that. And I'll do some slides, and then I'll stop and see if we can talk. And I believe that you all have the ability to unmute. And so if, Lauren, I think that's true, right? So if somebody wants to say something, feel free to use the chat. I'll watch the chat as I talk, and I'll chime in if I see something there. And then also feel free to unmute if there's something that you wanna talk about. I tend to talk fast. I share a lot of information. That's kind of on purpose because I want to try to reach everybody in the room. So again, feel free to have me pause or stop if there's something in particular that you want me to talk about. All right. So here's what I want to talk about with you today. I want to talk about trauma and its impact on the brain, the basic components of this term trauma-informed care, and discuss specific ways that UWMC is working to actively resist re-traumatization in healthcare. I am going to do a poll, actually. Let me stop for just a second and launch that. So I have one question in one, and then I'm going to ask another one. So if you could go ahead and answer that question first. I love what you just sent me that message, Hillary. That's amazing. I'm glad you're here, and perfectly fine to keep your camera off because she's multitasking in an awesome way. All right, so question one is, are you familiar with the term trauma-informed care? So I'll give you guys a chance to answer that. And then I'm going to go ahead and share that one. Okay, I'm going to go ahead and share results. It looks like about a third could have heard of it and could speak to it. 15% not heard of it, and 50% heard of it that maybe couldn't speak to it. Okay, I'm going to share the other question now. Let's do that one too. So this one is, have you heard of the ACEs study? So the Adverse Childhood Experiences Study. Yes, Anna, good mix. I love it when we have a mix. I promise you'll all walk away with something, even if it's, especially if it's because you've heard it from someone else who's going to chime in, because I think that is really where the best learning happens. All right, so we'll see who has heard of ACEs here. All right, one more second there, and then I'm going to go ahead and share the results of that. And we've got about 40% could speak to it. That's higher than your average audience, actually. 44% have not, and 16% maybe heard of it. Okay, great, a wonderful mix. Love that. Thank you guys so much for being willing to talk about that. All right. Okay, So this is our professional practice model at the University of Washington Medical Center. It really guides how we frame the things that we want to focus on when we're talking about patient care. And one of the tenets of that is relationship-based care. And that's really what this particular topic ties under. So just this month was published the updated Mental Health America. Every year they publish overall ranking for state of mental health in America by state. And so Washington State, we are currently ranked this year 32 out of 51, or 50 states plus DC, so 51. And basically you want to be state number one. State number one would have the lowest prevalence of mental health issues and would have the highest rates of access to care, because that's what this overall ranking is looking at. It's looking at mental illness, it's looking at substance use disorder. And in Washington State, they call mental illness, Mental Health America calls it mental illness. We say behavioral health disorder in Washington State. And that encompasses both a mental health disorder and a substance use disorder. And so you want to be state number one. We, as you can see, have really not, we've been lower than we'd like to be. Although this year's a little better than we were last. We had a dip. And then the other way that they look at this actually in a number of ways. They look at youth and adults, but I'm just going to show you two of their stats. So the other one is prevalence of mental illness. So this one is, again, if you're state number one, you have the lowest rate of behavioral health disorders. We are currently state number 32, but you can see that that has actually improved in the last 4 years pretty significantly. And I want to say that in 2017, we were actually 51 out of 50 states. So Washington State had pretty high rates. We know that the COVID-19 pandemic has really exacerbated behavioral health issues across our nation. All of the factors have really played into what is estimated by the advisory board, which is a healthcare consulting firm, an estimated increase in about 50% prevalence of behavioral health conditions in 2021 and a 20% increase in drug overdose deaths. So I just want to lay that foundation for you so you understand the prevalence. Oh, the other thing that I wanted to mention too is that overall, the newest stats just this month, 19.86% of adults in the US have a diagnosed mental health disorder. So almost 20%. Do you guys think that is higher or lower in Washington State? Yeah, higher. Yeah, most of you guys are saying higher. Yeah. So that number just this month in Washington State is 23.43. So almost a quarter of people in Washington State have a diagnosed behavioral health disorder. And I think the thing to know about that is diagnosed, right? Like we have way more, a much higher number of people who have a behavioral health condition rather than people who are just diagnosed and would be in that statistic. So I think that that's the advisory board statistics saying that 50% increase is probably not that far off. So let's talk for a minute about what is trauma. So trauma is a psychological emotional response to an event or experience that is deeply distressing or disturbing. So this is from 2021 definition. And there's different types of trauma. So acute trauma resulting from a single stressful or dangerous event, chronic from repeated and prolonged exposure. And this includes developmental trauma. And then, which is really before the age of 3, there's a lot of research being done on that particular topic right now. And then complex trauma resulting from exposure to multiple traumatic events. And this includes community trauma. So these types of trauma, I think, all of these things contribute to trauma-informed care. Trauma can show up in any of these ways. And I think right now, more than ever, we're really seeing this chronic trauma from the COVID-19 pandemic on many, many people. And we're going to talk more about that. So what is trauma-informed care then, or what we say TIC sometimes? It's an approach that assumes that an individual is more likely than not to have a history of trauma. And that's a really important piece of it. Because sometimes people will say to me, so if you want to use a trauma-informed care approach, do you have to know for sure if that person had a history of trauma? And the answer is no. trauma-informed care is a way for us to use a lens that we look and interact with one another. And there is a basic assumption that most people are more likely than not to have a history of some type of trauma. And there's some evidence behind that, which we're going to talk about. What it does is it recognizes the presence of trauma symptoms, acknowledges the role trauma may play in an individual's life, and really seeks to actively resist retraumatization. And this little phrase is often used to describe trauma-informed care, and it really resonates with me. It's a shift from what is wrong with you to what has happened to you. So there's sort of a curiosity that comes from it. So the idea is that each of us has our fuse, right? So at different points, we are more likely or less likely to kind of reach that place of stress. And the idea of trauma-informed care comes from the Triune brain theory. So it's the idea that we have these three layers to our brain. We have our neocortex, which is thought, logic, planning, our limbic system, which is emotional, and then our reptilian brain, which is that fight or flight sympathetic nervous system. And the idea of trauma-informed care is that based on past experiences, some people are more likely to access or even more live in that reptilian sympathetic part of their brain. And it's based on science. So this is the Adverse Childhood Experiences Study. So this was done by the CDC and Kaiser in the mid-90s. They looked at exposure to what they called ACEs, or adverse childhood experiences. They asked a giant study, 17,500 adults were asked about exposure to ACEs. These things included things like abuse, neglect, household dysfunction. So you can read them there. So emotional, physical, sexual abuse or neglect. And then just household dysfunction are things like substance use or mental health disorders in the household, or domestic violence, incarceration, and can even include parental separation, divorce, or discord. And what happened is when they did this study, they gave a point to every event that you'd been exposed to as a child, and then you got a total score. So over the last several years, there really has been an increased focus by the Institute for Healthcare Improvement on these ACEs. And we're now including things like bullying or systemic racism, other minority status or historical traumas that can play into somebody's ACEs score. So for every event, as I said, they got a total point. 67% of people had at least one ACE, 12.6 had 4 or more. And this is where the study got super interesting because, and you know, when I first learned about this, I think it was like 2016, the first time that I heard about this study. And I'd been a nurse already for, 22 years. And I stopped the person who was talking about this, the presenter at the end of the presentation, and I just said, like, people don't know about this. And she said, oh yeah, everybody knows about this. Everybody knows about this in healthcare. And I said, no, we don't know about this, because this is the part that really blew me away. If you had 4 ACEs or more, you had a giant increase in the number of negative health outcomes. So this was like 6 pages, and I'm just giving you a little smattering of example, but it's like 2 times the risk of migraine, 2.5 times the risk of COPD and hepatitis, 3 times the risk of cancer, autoimmune disease, heart disease, depression, suicide. So you can see, I don't think any of us are surprised by the fact that people who have a history of negative childhood experiences would be more likely to be depressed or suicidal, right? That's something that I think we've had awareness of for a really long time. But I think what was new for me, and maybe for some of you, is that also all of these negative health outcomes were much more likely to happen when somebody had a history of ACEs. So we're going to talk more about this. And I love that Jane's chiming in there and saying, am I not sharing my screen? Can you guys not see my screen right now? No? What?
I can see your screen.
I could see your screen just fine.
Oh, okay. Several people are just sending me a message saying they couldn't see it.
Yeah, I don't see it.
Oh, I don't know what to tell you.
I see the gallery view.
Can you see it now? No?
Yes.
Yeah.
Everybody else can. Okay, Lillian, you might need to work on that one. You might need to like play around with your settings and see if you might be able to see it better. Thanks for letting me know that.
Switch to speaker view in order to see the screen if you're only working in one window.
Speaker view. Oh, okay. I see. Lillian, you might need to switch back to speaker view. Thanks for helping her out, you guys. Appreciate that.
Thanks.
Yeah. Thanks for speaking up. Okay, so this CDC and subsequent studies really found this graded dose response between ACEs and negative health outcomes and well-being over the course of a lifetime. And, you know, I think somebody asked in the question, like, were some of those events more weighted than others? And then Lillian chimed in and somebody chimed in here and said they were all the same. Oh, Jane, thanks, Jane. All equally weighted. Yes. So in the original study, and I'm sure there's been other studies because this has been a huge focus, even though in Western medicine, we haven't really been talking a lot about this, and we're going to talk about that. But this is something that's gotten a lot of focus, especially over the last, say, 15 years. There's been a resurgence of interest in this. But the idea is that early trauma physiologically affects the brain, and MRI scans show measurable differences in the amygdala, or the fear response center. So the amygdala, so that's like our emotional watchman. And when I used to teach workplace violence prevention classes, I talked a lot about the amygdala because I basically describe it as like a giant sensor on top of someone's head. And when you have had a history of trauma, you become very good at watching for real or perceived threats in your environment and interpreting that. And so you just have like this hypervigilance where you're watching, and it really comes from needing to do that for your survival, right? Like needing to be vigilant. So does anybody know who this is? Anybody watch this documentary? Yeah, thanks, Elena. So this is Alex Honnold. So Alex Honnold, this is called Free Solo, and this is a documentary. He is a rock climber, and he climbed up 7,000 feet of, this is El Capitan, and he climbed up in Yosemite 7,000 feet of sheer granite with no ropes. So just like straight up the rock, like you can see, there's barely even any place for him to hold on to. So when I watched this documentary, yes, Elena, he has a unique brain. What I think about when I watched this documentary, I was like so amazed by it because when they did MRI scans of his brain, he showed almost zero activity around his amygdala. So the way that I've described this is if you have zero activity around your amygdala or your fear response center, you could be Alex Honnold. You could climb up rock, and we could argue, you know, like the people who were filming this passing out, throwing up because they were so sure this guy was going to die. But he was okay because this, you know, minuscule activity around his amygdala really enables him to not see this as the threat that we see it as. Whereas if you are somebody who's had a history of trauma in your life, you're going to be the opposite of that because you are going to have a hyperreactive amygdala and really be looking at things that maybe aren't a threat as the threat. So there's a lot of focus on communication. And these original discussions in like the mid 70s, I think it was. No, I think this was the mid 50s where it first started talking about like, is communication, how much of communication is nonverbal? So original studies looked at 7% of communication is verbal, 93% nonverbal. That's been highly disputed. People say that's a myth, that's not true. And I think the point of these studies, and I would say many people would argue that in most cases, about 70% of ongoing communication is nonverbal. And the point of this is to really understand that when you're communicating with somebody who has a hyperreactive amygdala, they are watching everything you do. They are watching to see if you judge them. They are watching to see if this is safe. They are watching very carefully to make sure that this is a safe place to be. And so what happens is we, as healthcare providers, as people serving the public, maybe have increased awareness around our tone, our body language, things that otherwise we might not have awareness around because that's being read by somebody who has this hyperreactive amygdala. So the idea, when they did the ACEs study, there were critics and people were like, wait a minute, didn't these people just engage in high-risk behaviors that increase their risk? Like, weren't they just, doing high-risk things in their life? And so the study, they separated that out to say, hey, was that actually a huge factor? And even without high-risk behaviors, these people were at risk. And the idea, the thinking behind that is this constant fight or flight stress response overacts overacting toxic stress, adrenaline, cortisol being released again and again becomes maladaptive. And so the idea is your brain, it's causing insomnia, your digestion slowing or stopping. This constant cortisol increases blood pressure, blood sugar, depresses the immune system. And so you see how over time we can have these negative health impacts that we're seeing in people who've had this history of trauma in their lives. So when this study first came out in the mid-90s, Dr. Robert Bloch, who is the former president of the American Academy of Pediatrics, said, wow, this is going to change everything. Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And there's just so much information that came out at that time saying, yes, this is what we need to pay attention to. And then I feel like I went to school in the mid-90s, crickets. And we really have not done an incredible job. I think social workers and people who work in behavioral health have an increased awareness of ACEs, but this is not something that we've really brought very well to our modern Western medicine. So it's changing, as I said. So there was a book that was written last year by Bruce Perry and Oprah Winfrey. So Dr. Bruce Perry, called What Happened to You? Conversations on Trauma, Resilience, and Healing. And I think the thing about this book that I really took away was the idea that each of us have this different lens through which we see things. So we have the event, we have the experience of the event, and then we have the effects. And that sort of explains how COVID has impacted us in so many different ways. My colleague, Marie Cockerham, who is our staff support specialist at the University of Washington, and I have been running these sessions called Got Burnout, which are really sessions aimed at our UW Medical Center employees to really just have a forum for people to talk about the isolation, the frustration, the fatigue, the exhaustion, like all of the impact of everything that we've been facing, the moral distress, the moral outrage. And if there's anything we've learned, there's a couple things we've learned, but I would say the biggest one is that everyone's experiencing some degree of isolation, right, throughout. And the second thing we've learned is, gosh, everybody has such a different experience. And it has a lot to do with the lens and the things that we've experienced in our own lives in the past. So Sam Himmelstein is an author in Redwood City, California. And he is a psychologist. He is a former incarcerated youth who works with incarcerated youth. I love his work. He has done a ton of stuff on mindfulness. If any of you work with an adolescent population, I highly recommend you check out his work because it's just amazing. And one of the things he shows is this depiction of, which I think gives a really good image of sort of how you have those roots that get laid down that end up showing up in the behaviors that we see that are, disruptive in our workplaces. And as I said, the Institute for Healthcare Improvement is really placing a lot of emphasis right now on like social determinants of health. They're talking about ACEs more. And this was actually put out by the CDC last year, showing how you have this historical trauma or ACEs and these things that disrupt our neurodevelopment as human beings and end up causing not only these adverse health outcomes and early mortality, but social, emotional, cognitive impairment. And yes, I'll be happy to share these slides, Rebecca. And ADHD, yeah, we'll talk about ADHD. I think any type of health outcome, there can be a link back to these ACEs. And I think it's worth it to check it out. It's worth it to look at research when you're looking at different health diagnoses, as far as the likelihood of, ACEs playing some degree of role. I think we're learning more and more. I mean, there was actually, I just read a study yesterday that was published and talked about in the Harvard Business Review. And they were talking about how, healthcare workers who've experienced like trauma and stress throughout the pandemic, that type of like distrust of your organization or feeling like you've been let down, the brain processes it via MRI the same way. That type of psychological pain is processed the same way as physical pain. So I think we're just learning a lot more about the overlap between that like emotional pain and physical pain and how those things come together. And this is an example too of sort of that, because this is from the Trauma Resource Institute, and this is really trauma theory on when you have, let's say, a traumatic stressful event, and then the black squiggly line is the zone of resilience. So that's, you know, our normal processing up and down, you know, of normal events. And well, what can happen is when you have a traumatic event, you can get stuck on in what we call hyperarousal. So think about hyperreactive amygdala, hypervigilance. This looks like anxiety, rage, anger, sleeplessness, chronic pain, flooding, hostility, rage, right? Or you can get stuck off in your parasympathetic. That looks like depression, fatigue, exhaustion, numbness, dissociation, disconnection. And so I think that this is just a really great example. This is not a new slide I've been showing, but this is a great example of how we can get sort of out of that autonomic nervous system. And I really like this quote. You might not remember it, but your nervous system does. The other thing that I just want to mention before I move on from this is that this is not just a COVID problem. In 2017, the World Health Organization said that by 2020, anxiety and depression were on cue to be the top 2 causes of disability worldwide. So throughout the world, anxiety and depression. So if you think about that as stuck on in your sympathetic and anxiety, stuck off in your, you know, or in your stuck on in your parasympathetic as hypoarousal depression. And you see how that sort of just gets out of whack, and we can get trapped there and looped there. One thing I'm going to mention here, because I know that many of us, especially those who work in healthcare, are more likely to be experiencing anxiety and depression right now. So there's 2 things that I just want to tell you that are sort of aside from this presentation, but there are 2 things that can deepen this zone of resilience. The first is self-compassion. So if you haven't looked at Kristen Neff's work, self-compassion.org, that is an incredibly powerful toolbox. You can do a little test and learn about your own self-compassion. Cultivating self-compassion is an evidence-based tool for helping to widen this zone of resilience. And the other thing that can help you if you get stuck on, like if you're somebody who leans more towards the hyperarousal or anxiety, that is breathing. So one of the things that it's self-compassion.org. Thank you guys so much. So I think, you know, breathing when you have a longer exhale. So there are things like box breathing or 4-7-8 breathing, where you breathe in for 4, hold for 7, push your lips and breathe out for 8. Those types of breathing techniques can stimulate your parasympathetic nervous system. So if you're stuck on, that has been really life-changing for me. When I have had moments of feeling really anxious or looping around that, if I do that kind of breathing, it really almost always brings me back to those breathing techniques. So I think that's a really powerful tool. And it looks like we've got some additional suggestions coming through, which I love. And, you know, sometimes it doesn't always show up in that fight or flight. Sometimes I think whenever I talk to nurses, I always talk about this other response, these freeze or fawn, because fawn is, you know, just as much can be a sign of a traumatic childhood. I know I have an ACE score of 5. I'm a nurse trying to, you know, I came to nursing to like make a difference in the world, totally see myself in that fawn category. And so I really think this is something that's just really helpful for people to lay eyes on and really think about your own life. And, you know, and again, from a place of Kristen Neff's work on self-compassion, I think it's really good to just notice it, be aware of it, and not really judge yourself for it. Like, you know, one time I had a colleague tell me, who does a lot of work in this area, that, you know, the way we show up in our lives is really representative of the previous 4 generations before us. And I thought that was just so powerful and really reflective. You know, it's that historical trauma, like what has happened to the previous 4 generations before us that has really led to how we show up in this life and what tools we're equipped with right away, you know. And I think just knowledge is power, so that you can, you know, do the best you can with those situations. And also I love that people are talking about The Body Keeps the Score. That's a really excellent book. And I just noticed this weekend that is the #1. It was the #1 bestseller recently again, which I think that book was written several years ago. Trauma, okay, Agency for Healthcare Research and Quality. So I'm sharing this because this is 2021, and trauma is a widespread, harmful, and costly public health problem. So we're paying attention. We're paying attention in a different way than we have in the past. So how does trauma show up for people? So this is also an excellent book. I don't know if any of you have heard about this. I know we're trying to bring this speaker actually to the University of Washington to speak soon. Laura Vandernoot-Lipsky, she's a social worker who has worked at Harborview, and she wrote this book in 2009. So this is not new, but she's been doing a lot of work since the pandemic because it's so applicable. So this is a great book for anybody who works. She's a social worker, but anybody who works in healthcare, public sector. When she's talking about trauma, she's talking about being exposed to other people's trauma. Yeah, Melissa, she used to work in the ED at Harborview. And what I love that her website has come up with these trauma exposure responses. So when we think about people with hyperreactive amygdalas, we think about people who've had trauma in the past, we see this stuff over here, right? All of these things that can show up: helplessness, hopelessness, exhaustion. And then what if I asked you guys, hey, is anybody relating to any of these symptoms over here throughout the pandemic? Is there anything like speaking to you, right? Everybody would be like, yeah, a number of those are speaking to me. And I think that just speaks to this complex trauma that we have all been experiencing as a result of the pandemic and the sustained impact on those of us, particularly who are working with the public. One thing I mention about this too is sometimes people can behave in a way that is really off-putting when they have had a history of trauma, and that will often show up as anger. And the reason I say this is because anger is actionable. So anger is something that we can do something with. It is really hard to sit with fear, with shame, with hopelessness, with powerlessness, with all of the things that we often will feel underlying how we show up with anger. So whenever you are working with somebody who leads with anger, first of all, I want to just make a shout out that like your safety is always first. So the first thing you do is make sure you and your team are safe. If you're working with patients, that your patients are safe. Trauma-informed care is a way so that you have tools in your toolbox so that you can know that how somebody might be reacting and try to work with that. But it's not a license to just like let anybody treat you any way they want. That's not what this is about. And so I just want to say that, like, sometimes people will lead with anger. You still are not somebody who, deserves to have someone yell at you. I think what happens when you look at this from the what has happened to you rather than what is wrong with you is you think to yourself, like, what could be going on for this person? What could be triggered right now for this person? And how could you maybe see them as a human being in a way that is not necessarily as a threat? One of the most powerful tools that Sam Himmelstein has given me in my own practice is he says, do not reactively flex your authority. When he's working with these incarcerated youth, if he reactively flexes his authority, he's always going to lose. So what he says is that, you should be curious and you try to like proceed with a plan. I actually have a tool that I think I have a slide on it, but I'll tell you what it is. It's TAP. So he says, take a breath, acknowledge how you feel. He says, even go a step further. Acknowledge that what you're witnessing is likely a traumatic adaptation and has nothing to do with you. Or you could be acknowledging that your own trauma is being triggered right now. And so you're getting really wrapped up in this. And then P is proceed with a plan, like be really thoughtful and intentional. It's really mindfulness. And when I say mindfulness, I don't want to lose anybody in the whole like meditative arena. It's really a moment. It's a moment of mindfulness. It's pausing for a moment and saying, okay, let me just come out of my like, limbic system, my emotions, and move into my cognitive domain, move into my brain where I can actually use rational thinking and decide, like, do I really want to be behaving this way? Do I really want to be reacting this way? Do I want to be curious about what this person is doing? And so the idea of trauma-informed care is to realize the widespread impact of trauma on others, on ourselves, recognize the signs and symptoms of trauma in patients, families, and staff, integrate that knowledge into policies, procedures, or practices if you work in an organization like the University of Washington, and actively avoid re-traumatization. So let me just pause right there for a moment. And I speak about healthcare because I work at the University of Washington Medical Center, but I know many of you work in a lot of different arenas. And so I would just like to ask the question, how do you think we re-traumatize people working with them? And you can be specific to your setting. Like when you're working with people in your setting, what is it that we likely do that could be re-traumatizing to somebody who has a history of trauma in their life? And feel free to like put in the chat or feel free to unmute and just say something.
Okay. My name's Erin Larson, and I'm a panel navigator, but I provide resources. And a panel navigator supports the primary care clinics to close preventive care gaps. So bottom line is, if you're going to call somebody asking for inquiry about a cervical cancer screening, what happens if they've been sexually abused? And the chart, that even if the chart is not the gospel, the chart may not even indicate that, because there could be X% of people that never communicated that. And I've really learned that my cadence can make a difference, because I get a very strong voice. I could talk really, really fast as my nature, but I actually have to change and soften my cadence. Be very careful and sensitive because it changes the course of the entire call.
Erin, you are so right. And I love that you said that. I love a number of things you said about that, but you're talking about a phone call where you can't even read body language, right? So you're talking about tone, you're talking about cadence. And I clearly, with this fast speech thing, have the same thing as you. So I have to be very intentional when I'm going to talk with someone that I, suspect. And this is the only time when we can assume anything in healthcare. We can assume that people likely have had a history of trauma. And so maybe we shift the way that we are acting, or our voice or our body language. Sometimes I will physically make myself smaller. Like I will squat down. If I'm worried about getting kicked, I might squat down a little further away, but making myself physically lower, or at least eye level to someone. Let's see, people are saying in here, yeah, we ask people to tell their story. Rachel's saying we shame or judge them. Yeah, and we can show that just through our body language or our tone. We ask, let's see, not reflectively, actively listening and validating. That one's huge, Hannah. Yes, active listening is a huge piece of de-escalation. It's a huge piece of being able, and I describe this as people needing to feel seen and heard. Ultimately, that's the goal, that people feel seen and heard. And so we can use active listening techniques to be able, nodding or, paraphrasing, clarifying, to have people feel like we are truly listening to them. In HR, failing to respond to problems or conflicts in the office that are brought to our attention. Yeah. Prioritizing workplace policies like cameras on meetings, personal attendance, without making space for different ways. Yeah, Deborah. Yeah, absolutely. Like making space for people to be who they are and to understand that people are bringing in that different experience. I think about that book, you have the event, you have the experience, and then you have the effects. And so just knowing that people are going to show up in a different way. And Jessica's saying code grays, putting people in restraints. Yeah. And a lot of the teaching that I've done in my previous role as the behavioral health CNS is about like, sometimes you need restraints because sometimes there is an immediate risk of harm to self or others. And that is the best way to protect people. But you don't want that to be the only tool in your toolbox. You want to have a whole arsenal of tools around de-escalation techniques, trauma-informed techniques, your body language, your tone, and all of those things. You want to try so much to be able to really connect to a person as a human being before we move to some of those other tools, which really segues very nicely into the research on mental health related stigma in healthcare. So there's this whole specialty of stigma research. And what it says is kind of a bummer about healthcare. What it says is that 16 to 44% of the time people feel discriminated in a mental health setting, and 17 to 31% of the time in a physical healthcare setting. So while we would think that healthcare is a really safe place for people, it often turns out that it's not. And I've had the incredible pleasure of partnering with the She Clinic. So I'm not sure if many of you are familiar with the She Clinic. It's the Safe, Healthy, Empowered Clinic on Aurora Avenue. And Dr. Maggie Green and her team provide incredible care for women, for female identifying people who work in sex trade. And they call it survival street-based sex trade on Aurora Avenue. And whenever, this is actually Maggie's slide, and she talks about, this is normally 90th and Aurora, the crossroads, but she describes it as it might as well be the intersections of homelessness, opiate use disorder, HIV, and sex trade. And one of the things that has been really moving for me is to hear the stories that are presented through the She Clinic. And so I actually just want to take about 5 minutes here. I know we don't have a ton more time, but I really want to share this with you because I feel like this is a really powerful way of understanding a population that is otherwise normally marginalized. So I'm going to go ahead and share this video with you. If you guys have sound issues, it's just an excerpt of this video, but this is Sparrow Etter Carlson, who's the director of the Aurora Commons. Actually, she just left. So she is the former director of the Aurora Commons on Aurora. So let me go ahead and share this.
So now I get to talk with you a little bit about the context of Aurora Avenue and the precious women that I have had the privilege of getting to know over the last 12 years. Many of us drive up and down Aurora Avenue. We see many women along Aurora Avenue. And each of them is a precious human being with a unique identity and unique ways that they make meaning of their life. And my heart and my ears have been attuned to their stories for many years. And what I have learned is that the majority of these women are treating their trauma and their medical needs with illegal drugs. And that many of them are engaging in survival street-based sex work. So we're talking sex work that is not done behind four walls. We're not talking about women that are engaging in sex work where they're posting online or have a phone that they can go through and choose who they want to service or not. We're talking about women that have to engage in sex work so that they can take a shower, so that they can maybe have food, and that they can get well so that they don't experience their withdrawal symptoms. And often these withdrawal symptoms is something that they have inherited from either a trafficker, a pimp, or sometimes even a parent who is dependent upon drugs themselves, or from a physician that was not moral in the way that they gave them prescription drugs. So a lot of their story has been inherited, and what we see in our everyday encounters is that their everyday existence is for their own survival and is also very much based on a transactional economy. And so as we spend our days with these women, we really do our best to try to take away that transactional encounters that they have to have and weave in, like I mentioned before, a relational relationship with them, and one where we encounter them as someone who has something unique to offer this world. These women are strong, they are brave, they present in ways that can look, can be disarming for us as people that are housed and that are educated, but they have so much to offer us in friendship and in relationship. And the thing that I love most about these women is that they are real. Like, so many of us have grown up in ways and been educated in ways where we hide our own addictions and our own shame and the ways that we deal with our own shame. But these women do not have the privilege of hiding. And I think there is much that we have to learn from them. But another thing you need to know about these women, and that is that the vast majority of them are extremely isolated. They are not welcomed anywhere. And the places that they are welcomed, they typically, again, have to perform some kind of transaction to get what they need for their everyday survival.
Thank you so much for watching that. If anybody is interested, I could send you the link to the rest of that video. It's about 45 minutes long and it's incredibly powerful. I feel like I've never driven down Aurora Avenue, and not really heard Lisa's voice in my head ever since that. I've just been so moved by their work. And what I want to talk about is, when Maggie talks about, Dr. Green talks about her patients who come to the emergency departments around Seattle, she really describes how their experience is so very different than hers would be if she were to go to the emergency department. And she talks about the many ways in which we unknowingly perpetuate this bias that we experience, that we have ourselves. So, through race, age, gender, somebody's attire, housing or not, appearance, and the chart is a very common way that she has described that we tend to pass on biases, or in report, pass on biases to one another. So one of the things that she's turned me on to is this project Implicit, which is a way for you to test your own bias. So it's all of these bias tests, and I can put this in the chat in a moment. But all of these bias tests where you can come and take these 10-minute tests, and it just tests your brain on where your biases lie. And this is really not about shaming. It's about just having awareness around what are your biases so that you can mitigate that when you're interacting with people and have awareness. Again, that mindful pause where you think about what your biases are and how you might want to be intentional about how you interact with someone. And to sum up here, I'm just going to say that here are the best practices for thinking about using a trauma-informed lens. So building trust and transparency, really asking permission before you touch someone, creating a safe environment, just thinking about that somebody has that hyperreactive amygdala and how might they feel unsafe. So making sure you tell them what you're doing or ask permission before you touch them. Again, cultivating that culture of consent, that consent can be withdrawn. There's a really wonderful toolkit. I'll put this link in the chat in a moment too. This is iwantrest.com, and these are practical tools for how we can interact with people from a trauma-informed lens. So I don't think any of these will be really surprising for people, but just giving people actual space, again, that warm, inviting approach. A lot of times people make decisions right when they walk into a place, whether it is safe or not. And those very first interactions with somebody who answers the front desk or answers the phone has everything to do with how the rest of that interaction is going to go. And I'll end with this quote here: people start to heal the moment they feel heard. So again, I feel like it's so much about what all of us want as human beings, is really that idea of, oh, thank you for putting the links in there. For all of us really want to feel seen and heard, right? And so the idea that we're just trying to connect with and offer that to the public that we're serving goes a long way. All right, I know there's been questions that maybe I have not gotten to. So let me scroll through. And while I'm looking, if anybody wants to unmute and say anything or ask anything, feel free.
I apologize if this has been talked about. I had to step away for a call, but can you tell us anything about how cortisol affects or can alter DNA during pregnancy? This is something that I have in the back of my mind from like an old anatomy and physiology class.
I would say it's probably the same. I can't say during pregnancy, and maybe there's somebody on who can speak to that, and feel free to unmute if you can. I think what I would say is the effect of cortisol again and again and again raising your blood sugar, raising your blood pressure, lowers your immune system overall. So I would assume that that same impact would happen across, the placenta when you're pregnant, but I can't say for sure that I can speak to that from a physiological standpoint. I can tell you that there's a lot of research being done by the IHI right now on just historical trauma in general and how trauma in those past 4 generations before you shows up in your life. And so I just think there's so much more that we're just starting to scratch the surface on really understanding that. The other thing that I want to say in the chat too is I see some of you guys talking about eye movement desensitization and reprocessing, so EMDR. And I don't have a lot of experience with EMDR, but I see Tanya in particular is saying it changed her life. So I'm wondering if she might be willing to say something about that. Or anybody who said anything about EMDR.
Yeah, I guess I can talk about EMDR. So I was born in 1981 and I grew up in kinship care with my grandparents, which I guess at the time people didn't realize creates a lot of childhood trauma, even though they were family and my grandparents and I loved them.
Mm-hmm.
And just a lot of other things kind of piling up throughout the course of my childhood. And in spite of all of that, I coped very well. I went to college, I got a degree. I've been working at UW for almost 15 years. But I always felt like there was something wrong with me and I would have a lot of anger and I had a really quick temper and I'm like, what's wrong with me? And I had done therapy before and it is like talk therapy and it sort of helped, but I never really felt like I was better. And then I discovered the Body Keeps the Score book and I read it and I was like, oh my God, I need to find a therapist who does EMDR. I found one. I started EMDR and it took some time, but all of a sudden it just clicked and it really changed my life. Like I still have a quick-ish temper, but it's slower. I have a lot better coping skills and I just feel my level of calm throughout the day is, even when things are not going as expected, unexpected things, is just so much better. And especially in light of the pandemic, I think if I hadn't done the EMDR, I would have been even more kind of all over the place. So, I mean, I can't say enough good things about it. It's hard. It brings up things that you kind of don't even remember and you didn't realize how deeply they affected you, but it was life-changing and I recommend it to anyone.
Thank you, Tanya, so much for being willing to share your
Yeah.
story. I love it. And she's describing a form of psychotherapy, and there are, multiple forms of psychotherapy. And I think that is one that, you could find a lot of information on. I think that your story is beautiful. And I think it's about people finding what works for them. That's a really, really powerful story. And when you say something is life-changing, right, that's something that I certainly pay attention to. So really appreciate you being willing to share that.
Sheree,
yeah.
I went through the chat and I found any questions that were asked. I can go through and just see. Did you answer the one about the correlation between ACEs and ADHD?
Yeah, just, I don't know specifically about ADHD, but I can tell you that the study is astounding. And I don't know that in the mid-90s there was as much focus on ADHD, but it's astounding as far as how many physiological conditions can have some link back or connection or more likelihood if somebody has a higher number of ACEs. So I wouldn't be surprised if there was a correlation there.
All right. And then another one was, how do diagnoses of behavioral health and mental health differ? Are they all under the same umbrella?
So in Washington State, we recently, I think it was last year, or maybe even it was the year before, it's blending together with the pandemic. We started calling behavioral health disorder. That's the term that Washington State DOH started to use for mental health disorder and substance use disorder under one umbrella term, behavioral health disorder. That is not necessarily national language. Like I said, Mental Health America still uses the term mental illness. That's sort of older language that I don't think as many people are using, but that's the language being used there. So I think it's differing, but in Washington State, I think we try, and at UW, we try to use behavioral health disorder.
All right, that makes sense. Thanks. And then the last one I saw was is there any way to prevent health issues resulting from ACES?
Any way to prevent health issues? Oh, what a good question. I think there's probably therapists on this call who could answer that better than me. But I guess what I would say from my own life and from Tanya's story is therapy. That's what I would say is really when you have a history of trauma, it's really about becoming an observer of your behavior. And I love the way Tanya so beautifully described how like she still has a propensity for that. And I'm the same way. Like if I'm tired, hungry, like all the things, and I don't have access to my higher brain, then I'm probably not going to behave as well as if I really am being thoughtful, because, you know, I'm wired in a different way than the way that I've had enough therapy to like overcome. So I think a lot of people are that way. And so I would say therapy is probably the best way to navigate that. Yeah, I love that. Kiana's saying research points to increasing resiliency factors, including connection to one caring, loving adult. Yes. If you have a connection that you can point back to one person in your life, and I think even more than being caring, which I love that you said that because I think that's a huge piece of it, but I also think it's validating your feelings about something, because a lot of times in those situations, people are like sort of taught to not trust their own internal feelings. And so if you have somebody who validates you, that is actually a really powerful resiliency tool. Yeah, there's a lot of focus on trauma and resiliency in children. There's books people are suggesting, which is wonderful. You know, this is just a very high level discussion about this. This is really to begin to talk about it. The University of Washington, Montlake and Northwest campuses are bringing in a program called the WELL program, WELLE, and it's basically a workplace violence program that is for healthcare workers with a trauma-informed lens. And so this is something that we as an organization are trying to make a conscious shift towards, really making sure that everybody has, because I would say that we've been starting to teach this way for a number of years, but this is not something that is really strongly embedded. So I know we're out of time. Thank you guys so much for being here today. I really appreciate you taking this hour out of your day to talk about such an important subject. So thanks again. I'll make sure I send my slides on to Lauren.
Thank you. Sherry, can I stay for a second? And I have a question for you.
Yeah, sure.
Can you speak just a little bit about the shortage of mental health care within the university system and also outside the university system here in the Seattle area?
Sure.
Like Erin, I'm a navigator and am asked so often, multiple times a day, to help someone find counseling or therapy. Our social workers within the system are so overwhelmed and impacted, and we're seeing that everywhere in Western Washington. So how can you speak a little about that and how maybe we can find resources?
I think what I would say about that is at this point like a legislative level, because we, as you can see, I have a little bit of hope that we are slowly eking up in our number of like overall ranking of mental health in Washington state. I think there's been a lot. I know many of you know that there's a behavioral health teaching facility being built on the UW Northwest campus in, I think, 2023 or 24. And this is really about the state partnering with funds to be able to provide expanded behavioral health services. I think, you know, there's been a lot of talk. I know Charity Holmes is our assistant administrator of behavioral health at Northwest and Montlake, and she's been involved with our legislators trying to make sure that we not only build a hospital, but we have resources for people to be discharged into the community, because what can happen is you can just have the bottleneck of people who are in this expanded 150 bed, you know, potential space for behavioral health patients. And then what about those community resources that are out there? Kimberly Mosoff, she is Disability Rights Washington. She's a lawyer. And she's been talking a lot about how the prison system isn't the right place for people who have behavioral health disorders, and how, you know, they go and they get no care and they get isolated. And it's basically the opposite of what you need to help somebody move through a behavioral health crisis. So there's focus being put on it all around the state. I can't speak myself to what is actually being done right now. I can tell you that the University of Washington is very much involved in those conversations as we build this behavioral health teaching facility. And yeah, and I agree with you, Monica, the need is tremendously great. I think there's focus in a way that there hasn't been. There's focus on healthcare in general in a way that there hasn't been with the pandemic. And I think the pandemic has also maybe normalized behavioral health a little bit more. Like maybe it's not as a taboo as a subject as it was. People are recognizing that this is something that everybody is dealing with. So I'm hopeful, but I can't say there's a quick solution for any of it. Somebody asked me in the chat about the WELL program, and that is the University of Washington inpatient Montlake and Northwest campuses are bringing in the WELL program in 2022. Annie Tsai, Tricia Webb, those are our behavioral health clinical nurse specialists, and they just attended training last week, and they're working with our public safety team to bring that program.